So this is such a common disorder, so it's relevant to all different patient populations. If you're wondering if you have lactose intolerance, what are the signs and symptoms to look for? If you're really not sure how to get tested for it, and then if it comes back positive that you are lactose intolerant, how can you manage it? So the objectives for this talk are to understand what lactose actually is, what kind of disaccharide it is and how it's broken down, understand the signs and symptoms of lactose malabsorption specifically and intolerance, determine whether or not you actually need testing for lactose malabsorption. We can discuss treatments for lactose intolerance, and then finally recognize the differences between lactose intolerance and an actual allergy to milk. So before talking about milk specifically, it's worth noting how much we as Americans love to eat carbohydrates. And carbohydrates are essentially just sugars, and they can be found in various different products. Carbohydrates aren't only in candies and fruits and sweet things, but they can be found in grains and meats and different types of vegetables. So the average American man eats about 220 to 330 grams a day of carbohydrates. Women are generally a little bit smaller. We eat a little bit less carbohydrates, about 180 to 230 grams a day. Polysaccharides, so that means that the carbohydrates that are derived from starch, from plants, glycogen from meats, makes up about 50% of the total carbohydrate intake per day, whereas disaccharides, that includes sucrose, lactose specifically. Trehalose is the disaccharide that's found in mushrooms, makes up about 30 to 40% of our daily carbohydrate intake, and then monosaccharides, such as fructose and glucose, makes up the minority, about only 10%. So we'll just go through some different pictures of carbohydrates. So we're going to talk about dairy, we're going to talk about, this is trehalose, we'll not talk so much about trehalose, and this is just what we think of when we traditionally think about sugar, so a lot of fruit. So there are different types of disaccharides and disaccharidases. So disaccharides refer to a type of sugar where it's essentially two sugar rings fused together. And disaccharadases are the enzymes that break down those disaccharides, so those two rings of sugars into monosaccharides. So sucrose, isomaltose, maltose, and trehalose are all different types of disaccharides. And the disaccharadases that break them down have very similar names too. So sucrase, isomaltase, maltase, and trehalase would be the disaccharadases that break down those disaccharides. So we'll focus today on lactose. And as you can see, there's a picture of the molecular structure of lactose. Lactose is broken down by the enzyme lactase to two monosaccharides, specifically galactose and glucose. So when we think about where in the body this is happening, so where are these sugars being broken down into these smaller building blocks and where are those being absorbed, it's happening in the small intestine. And the small intestine is actually the longest portion of the intestinal tract. So it's about 20 feet in length for the average person. And you can see in that center picture, it looks like there's a bunch of finger-like projections in the small intestine. Those are called villi. And actually on all of those finger-like projections are even more microscopic finger-like projections, and those are called microvilli. And that's the picture on the right. So this is where the breakdown of these disaccharides and the absorption of these disaccharides is taking place. It's at an area in the small intestine called the brush border. The three parts of the small intestine are the duodenum, which is the first part, the jejunum, which is the second part, and the ileum, which is the very last part. The enzyme concentration and the absorption is highest in the jejunum, and then the ileum, and then the duodenum. So this is a schematic just detailing what's actually happening at the brush border once these disaccharides are broken down into those basic building blocks. Glucose and galactose, the two building blocks of lactose, are actually transported into the cells through active transport. And that just means that the cell needs to use a little bit of energy to get those sugars into the cell, versus fructose, and another monosaccharide that is just absorbed passively. So when we think about disaccharidase deficiency, that means that there's a deficiency in the disaccharidase to break down the disaccharide. And so if that lactose disaccharide, so if you picture those two rings of sugars, if those are not broken down into the galactose and glucose, the monosaccharides that can be transported into the cells easily, then what happens is it travels through the intestinal tract not broken down and then hits the colon. And the colon is where it's full of bacteria, and the bacteria can still use that sugar and undergo fermentation. So disaccharidase deficiency, so this includes lactose intolerance, but also deficiency of any of those disaccharadases, it can occur at any life stage. So it can occur in children, middle life or mid-age, and then end of life as well. well. It can be genetic, meaning that you have a genetic mutation that predisposes you to having enzyme deficiency, or on the other hand, you can have a genetic mutation that makes it such that lactase is persistent, so you can digest dairy all your life. It can be physiologic, so when we talk about physiologic, it's physiologic to have lactase non-persistent. So as we get older and we're no longer babies, we're not breastfeeding, a lot of adults will lose that ability to make that lactase enzyme. We don't consider that a disease, we consider that to be physiologic. And then disaccharidase deficiency can also be secondary to disease. We talked already about that brush border in the small intestine, all those villi and microvilli where this breakdown of these sugars happens and absorption occurs. If there's disease that damages the small intestine or damages that brush border, then we can have a secondary disaccharidase deficiency. So when you have a deficiency in that disaccharidase or the enzyme that breaks down those two sugar rings, then basically that sugar intact hits the colon. And while it's traveling through the intestinal tract, it's also drawing in water. And what happens is it's increasing that osmotic load, and that results in the symptoms of disaccharidase deficiency or lactase deficiency. So namely bloating, diarrhea, but also can cause gas and abdominal pain. Some of the secondary causes of disaccharidase deficiency are, again, these are diseases that usually cause some kind of inflammation and damage to the small intestine. So the first is celiac disease. Celiac disease is an allergy to gluten. Inflammatory bowel disease. So this is what we think maybe partly an autoimmune response, probably also secondary to some changes in the microbiome, but it results in a lot of inflammation in the intestinal tract. And specifically Crohn's disease, if it's affecting the small intestine, can cause a secondary deficiency. Allergic enteropathy, so allergies that affect the small intestine. Mucositis, this is typically in the setting of chemotherapy for cancer. Small intestinal bacterial overgrowth, which is an overgrowth of sort of the wrong types of bacteria in the small intestine. And then Giardia. Giardia is a parasite, a parasitic infection that can also cause a lot of bloating, gas, diarrhea. And the picture on the right is an illustration of Giardia, but this is actually kind of what it looks like underneath the microscope. It has what's called an owl's eye appearance, but those actually aren't eyes, they're just sort of inclusions, but that's what Giardia tends to look like underneath the microscope as well. So lactase deficiency specifically is a deficiency of that lactase enzyme, so the enzyme that breaks down lactose, that disaccharide. It's pretty common. The estimated global prevalence is about 68%. The prevalence is lowest in the Nordic countries. So in Northwest Europe, incidence is probably less than 5%, and the incidence is highest in the African countries, Asia, and the Middle East. Lactose intolerance specifically means that the patient or the individual has lactose malabsorption, meaning they're not breaking down that sugar, they're not absorbing it, and they have symptoms. So the symptoms that we talked about, the diarrhea, the bloating, the gas, and the abdominal pain. So how do you test for it? We'll go through all of these tests in detail, especially if you're thinking that you might have lactose intolerance, but you're not really sure and you've cut out some dairy, but you're still having some symptoms. Then you can see your primary care doctor or your gastroenterologist about testing just to solidify the diagnosis if it's unclear. The first test that we'll talk about is the hydrogen breath test. So the hydrogen breath test does give you some lactose, so it challenges you with lactose. Because of that, we can assess symptoms. There are some limitations of this test that we'll talk about, but really we think it's probably the test of choice. For the hydrogen breath test, before you even get to the clinic or the laboratory where it's going to be performed, the doctor's office will usually send you some information regarding how to prepare for the test. There's a fairly strict diet that you have to adhere to the day beforehand, something that we refer to as a low fermentation diet. It's pretty bland at our center. We ask patients to just eat rice, potatoes, chicken breast, not with too many seasonings or spices. And then you want to be fasting for at least 12 hours before the test, the day of the test. You don't want to be smoking or doing any kind of really excessive exercise. Then you get to the testing center or the laboratory, and really all it involves is you blowing into bags. And the bags are then tested for the presence of CO2, hydrogen, and methane. And hydrogen and methane, we know, are only created by the gut microbiome. Our cells do not secrete or ferment hydrogen and methane gas. So you would first come in, you would blow into a bag, and we would get what's called a baseline. So we would get your hydrogen, methane, and carbon dioxide at baseline. Then you would ingest 25 grams of lactose. So we would give it to you in sort of a sugar substrate. And then over the next 3 hours, hours, every 15 minutes, you're blowing in that same bag. And we're specifically looking at the hydrogen level if we're testing for just lactose intolerance. What we're looking for is at any time during the test if there is an excessive rise of hydrogen. That means a rise of hydrogen by more than 20 parts per million. And on the left, we see a positive breath test. So that hydrogen, which is the line on the top, is rising by more than 20 parts per million, whereas on the right, a normal breath test, we're not seeing that. And the science behind this is that if you have enough lactase and it's breaking down all the lactose that we give you, then those two building blocks, the galactose and the glucose, are all getting absorbed. So no sugar is really hitting the colon. And again, the colon is where the bacteria are fermenting the sugars to give you that gas. Some of the drawbacks of this, though, are that it will not differentiate between lactose malabsorption and SIBO, or small intestinal bacterial overgrowth. So small intestinal bacterial overgrowth, again, is the overgrowth of bacteria that cause a lot of symptoms, specifically in the small intestine. And if you have too much of that bacteria in the small intestine, then as that lactose is traveling through your intestinal tract, even if you have enough lactase to break it down, those sugar byproducts can still be used by that bacteria. So we recommend that before anyone undergo a lactose hydrogen breath test, that they have actually what's called a lactulose hydrogen breath test, which is the test for small intestinal bacterial overgrowth. This is just the schematic that we talked about, in that if the lactose is not being broken down, then it's going to hit the colon. The colon is where it undergoes fermentation. We can detect that in the breath on the breath test. And then typically patients will have diarrhea, abdominal pain, bloating. And during the test, also when you're taking that lactose load, if you're having a lot of symptoms, that can be pretty indicative of lactose intolerance. The next test we'll talk about is the lactose tolerance test. So similar to the hydrogen breath test, you do get a lactose load, so you can assess your symptoms from the test. It's also a fairly low cost procedure, but it is a little bit more invasive than the hydrogen breath test. So for this lactose tolerance test, again, you're also getting in a lactose load, and it is 50 grams instead of 25. So you do take in more lactose with this test than with the hydrogen breath test. Before you take in the lactose load, we measure a plasma glucose, and then afterwards we measure at 30, 60, and 120 minutes after ingestion. And what should be happening is that when you take in the lactose, if you have enough of that lactase, and again, the building blocks get broken down, you absorb them, we should see is an increase in the plasma glucose, so the glucose that we can assess from your blood. If the increase in plasma glucose is less than 20 and patients have symptoms suggestive of intolerance, so the diarrhea, the bloating, gas, or abdominal pain, then that is diagnostic. But this has been largely replaced by the hydrogen breath test. I have advantages and disadvantages. The advantages are that it's not very invasive, it's low cost, widely available, and it can assess your symptoms in addition to looking at something objective. Some disadvantages are that it is more invasive than the hydrogen breath test because we have to be drawing your blood, so you have to be poked, and that's not comfortable for most people. Again, largely replaced by the hydrogen breath test. Next, we'll talk about the duodenal lactase activity. So duodenum is that first part of the small intestine. This is probably the best test in terms of sensitivity and specificity for not just lactase deficiency, but all of the disaccharidase deficiency. But it's also probably the most invasive. So we'll go over that in a little bit more detail. So the disaccharidase assay, the reason why it's the most invasive of the different ways to test for lactase deficiency or disaccharidase deficiency in general is because it requires an endoscopy. So what endoscopy means is that you would come into a procedure center, surgical center, or my group does it in the actual hospital. You would be fasting the night before and then undergo some type of sedation, whether it be conscious sedation or deep sedation. So they put you to sleep because it's a fairly uncomfortable test. Once you're asleep and comfortable, we introduce a long flexible camera called an endoscope into your mouth, and we look at your esophagus, your stomach, and the first part of your small intestine. So for the disaccharidase assay specifically, during the endoscopy, we take 2 to 3 biopsies from the distal duodenum or proximal jejunum. So that's between the first and second portions of the small intestine. We place those biopsies directly into an empty Eppendorf tube. We place that on dry ice, and on dry ice we ship it overnight to usually to Mayo Clinic, but there's a couple different laboratories around the country that perform this type of assay. The turnaround time is typically around 3 to 7 days, but again, it tests for multiple different types of disaccharidases, not just lactase. So in 3 to 7 7 days, we get results telling us how much lactase, sucrase, maltase, and palatinase the patients have. There are advantages and disadvantages of this test. The advantages are that we consider it a gold standard. We can assess for multiple different types of disaccharidases. And of course, it can also differentiate between primary and secondary. So is this a decreased production or is there damage to the small intestine? Some disadvantages are that it is expensive, it's invasive, you have to undergo a procedure, and we know that the enzyme distribution is patchy. So there can be false positives. On the assay, it may look like there is a deficiency in some of these enzymes, when really it's just because the samples that we took may have sampled areas that didn't have as much of that activity. So those are things that we always keep in mind when we are doing this test and when we are interpreting these results. The last test I'll talk about is a genetic test for specifically the lactase persistence and lactase non-persistence. So this is a test specifically for a chromosomal mutation. We know that the lactase persistence gene in Caucasians is due to a gain-of-function mutation on chromosome 2 in this very specific location, where the cytosine is now a tyrosine. And so that has to do with sort of the DNA building blocks, but that mutation allows mostly Caucasians to have lactase production throughout their entire life. And that's what we call lactase persistence. So in Caucasians, this genetic mutation allows them to be able to digest dairy basically for their entire life. Caucasians specifically who do not have this gain-of-function mutation, so have what we call the CC genotype instead of a CT or a TT genotype, they have about an 88% sensitivity, 90% specificity for primary lactase deficiency. If we have a Caucasian patient who for some reason can't undergo the other types of tests that I talked about, we could always do a genetic test to see if they have this specific genotype. Some advantages and disadvantages of this test. Advantages are that we can identify very specifically whether or not patients have this mutation. A lot of disadvantages though. One, it's fairly expensive. Genetic testing hasn't reached the stage where it's inexpensive. And I think most importantly, it's really only applicable for the Caucasian population. So if you're not Caucasian, then this gain-of-function or mutation or lack of mutation isn't going to be relevant. So let's say you have either received testing that tells you that you have lactose intolerance, or you're pretty sure you have it because every time you drink milk or have ice cream, you have explosive diarrhea. How do we manage it? The first step is a low lactose diet. That means that you're really cutting out a lot of dairy products. And sometimes we do that, not just low lactose, but no lactose diet, just to see if symptoms improve. If symptoms improve, then it's very likely that you have at least malabsorption, and with the symptoms improvement, then lactose intolerance. If you're cutting out dairy or even just cutting back on dairy, it's important to have your primary care doctor monitor your calcium and vitamin D levels, because that's where a lot of people are getting their calcium and vitamin D. And if those become low, then it's important to supplement with calcium and vitamin D to try to avoid long-term effects such as osteopenia or weakening of the bones or frank osteoporosis. Luckily, there's also a wide range of lactose-free dairy products. They go by different brand names. Lactate is a popular one, but there are other even generic supermarket brands that market lactose-free milk, lactose-free ice cream, and lactose-free yogurts. Sometimes those lactose-free products are milk products, so dairy, that just has the lactase enzyme added to it. So if we combine dairy products with that lactase enzyme, then it breaks down that lactose for you. Of course, there's also non-dairy lactose-free products, so soy milk, oat milk, almond milk, etc. And then if you can't take out dairy because you just love it too much, or it's hard because of your cultural diet or what your family likes to eat, you can always supplement your diet with lactase. So again, Lactate is a popular company that manufactures the lactase supplementation, but now it's generic and you can find many different brands can make it. This is just a pill that contains the lactase enzyme. It's recommended to take with your first bite of anything that contains dairy. Of course, When we think about lactase deficiency, it's a spectrum. Some patients with lactase deficiency still can make some lactase and some don't make any at all. So how much of this supplemental enzyme you need kind of depends on how much you make and how bad your symptoms are. It also depends on how much lactose you're taking in. So if you're going to drink something like a large milkshake, then you would probably need more than one tablet. If you're going to be nursing that milkshake for an hour, then probably you want to take some more as you're working on that milkshake. This is just a table showing at first the different types of milks and the different lactose contents they contain. So whole milk and skim milk contain anywhere from 9 to 14 grams of lactose per cup. Buttermilk is similar. Evaporated milk and sweetened condensed milk, which are sort of concentrated milk, contain more lactose. Lactate milk, which is just milk that has the enzyme added to it, still contains a little bit of lactose but less. Goat's milk contains less than the condensed milks, but about the same as the whole or skim milk. When we think about yogurts also contain lactose. There's a wide variety of lactose-free products and non-dairy yogurts as well. And then another common food group that contains dairy are the cheeses. So we can see that cottage cheese contains a wide variety of lactose depending on the brand and how much fat there is as well, but 0.7 to 4 grams of lactose per ounce. The aged hard cheeses such as cheddar and Parmesan we can see contain much less lactose, so those are usually better tolerated. The part skim low moisture mozzarellas as well, and we compare that to the ricottas, which usually contain more lactose, so harder to break down. And then cream cheese falls within that lower range as well. I wanted to spend time just contrasting lactose intolerance to a milk allergy, because some patients will say, oh, I'm allergic to milk, but they just really mean that they get diarrhea and gas from it, whereas milk allergy is actually a pathologic entity. So milk allergy or cow's milk allergy is an abnormal immune system response to proteins that are found in milk. Mostly we're talking about casein and whey. It's actually the most common food allergy in young children and relatively uncommon amongst adults. It affects about 2% of children under the age of 4, with a greater prevalence in boys. In adults, it's much less common. It only affects about 0.1 to 0.3% of adults, with a female predominance. And in the US, so remember when we talked about the prevalence of lactose intolerance, it was more common in Blacks and Asians. For when we're talking specifically about cow's milk allergy, Blacks and Asians actually have a 50% lower risk than white or Caucasian participants or individuals. When should we suspect that we have an actual milk allergy? So there's different symptoms that we look for depending on whether it's IgG mediated or non-IgG mediated. And IgG is just a specific type of antibody that is active in allergic reactions. We're talking about kids now, so if you're concerned about your kids because it's very uncommon in adults, symptoms of an IgE mediated milk allergy, those symptoms tend to occur within minutes to 2 hours after ingestion. And the tummy reaction means abdominal pain, upset stomach. It can be explosive or profuse diarrhea. You can see a skin reaction, usually that's a rash or hives, and you can have respiratory reactions too, so shortness of breath, coughing. And the table on the right just talks about these types of symptoms in more detail. So the skin reactions can be feeling flushed as well, angioedema, which is swelling. You can feel like your hair is standing on end. Some oral symptoms can be an itching or tingling of the mouth or the tongue. Some of these respiratory reactions can be itching in your nose, congestion, a runny nose, sneezing. Laryngeal can be hoarseness, dysphonia, so a change in your voice, itching and tingling in your throat. Of course, it can result in shortness of breath, chest tightness, wheezing. Cyanosis means you're looking pale, your lips can turn blue, really a sign that you're not oxygenating well. In the GI tract, again, we talked about the diarrhea, but you can have vomiting, nausea, abdominal pain. Dysphagia means difficulty swallowing. Things feel like they're getting stuck in the neck or chest region. Cardiovascular symptoms can be feeling dizzy, syncopizing, meaning fainting. You can become altered, meaning your patients aren't acting like themselves. They can be very confused. You can have palpitations, meaning you feel like your heart is racing. Neurologic signs or symptoms can be a lot of anxiety. You can have itching around your eyes. So these are just vague symptoms of an allergic reaction. When we think about the non-IgG mediated symptoms of milk allergy, these symptoms are typically occurring more than 2 hours after ingestion of the dairy. So the food protein-induced enterocolitis. This typically presents with severe vomiting and diarrhea 2 to 4 hours after ingestion. And this vomiting and diarrhea, especially in young children, can lead to dehydration, lethargy, they have no energy, and even shock. Chronic exposure to especially babies who have this milk allergy can result in regurgitation, meaning they're bringing up a lot of food, diarrhea, failure to thrive, meaning the kids aren't gaining weight, and hypoalbuminemia, so that means low protein levels in the blood. Food protein-induced proctitis or proctocolitis. This specifically means that it's resulting in inflammation in the rectum and or the colon. Usually presents by 6 months of life, and patients usually have blood-streaked, mucus-containing loose stools or diarrhea. So if babies are having specifically bloody diarrhea, then this is something that the pediatrician usually will test for. How do we actually diagnose a cow's milk allergy? First, we want to get a history of those typical allergic symptoms, that diagram and that table that we talked about, and then you want to be able to detect positive tests for specific IgE antibodies. There's a couple ways to do so. Probably the most common is skin prick testing. As adults, some of us have to undergo skin prick testing too. We have unexplained allergic symptoms, but what they do is they give you a drop of allergen, they give you a small skin prick, and then they look at the skin reaction. So what we're looking for is a wheal. And what a wheal means is a raised sort of red bump wherever the skin prick was. For children who are over 2 years of age, we're looking for a wheal that's 8 millimeters or larger. In children less than 2 years of age, that cutoff is 6 millimeters. If we're not undergoing skin prick testing, another way that we can assess for these antibodies are through the blood, and we're looking for specific serum levels. How do we manage a cow's milk allergy? One of the first things that we should do if we know that either we as adults or children have a cow's milk allergy is to have an epinephrine autoinjector, also known as an EpiPen. So particularly when the symptoms are affecting the respiratory tract and patients have tingling in their mouth, tongue swelling, shortness of breath, the EpiPen is something that you would inject typically into your leg if you are exposed to dairy. This is common in patients also who have severe allergies, for example, to peanuts and different types of nuts. In children, we know that children can grow out of it. So some pediatricians will do serial testing to see if there are lower IgE levels over time, looking specifically at that downward trend. And then if we think that the children are having less and less of these IgE levels, they can always give them some oral food challenges. We also know that approximately 70% of children who have a cow's milk allergy can actually tolerate cow's milk that has been extensively heated. So it can be the case that they are allergic to milk or room temperature or cold dairy, but if it's heated or cooked in something, then they may be able to tolerate that better. Some take-home points: lactose intolerance specifically refers to lactose malabsorption from decreased lactase production and the typical symptoms of gas, bloating, diarrhea, and or abdominal pain. The prevalence of lactose malabsorption, or specifically lactase non-persistence, is highest in Africa, Asia, and the Middle East. The treatment is either the avoidance of dairy or replacing the lactase with supplemental lactase. Remembering, if you're avoiding dairy, to monitor calcium and vitamin D levels to try to avoid osteopenia, osteoporosis. This is in contrast to cow's milk allergy, which is caused by an abnormal immune response to the proteins contained in milk. This is most commonly seen in children, but most children will grow out of it over time. And when it's seen in adults, it's usually acquired in adulthood. This is my group at Cedars Sinai. We have 6 adults, full-time GI motility specialists, and a pediatric GI motility specialist.
Are there any skin symptoms that can be related to lactose intolerance, or are the skin symptoms more indicative of something like a milk allergy?
If we're talking about adult onset eczema, if we look at the prevalence of a cow's milk allergy, it is pretty uncommon. But it's not a well-described symptom of lactose intolerance. So it's not uncommon that patients will say, oh, when I have dairy, my skin breaks out, or I have different types of skin symptoms, but they're really not well described. I would say that it might be worth pursuing the milk allergy route if there are other symptoms as well. In addition to the eczema, there are more allergic type symptoms. So like we talked about, neurologic signs or symptoms, cardiac, respiratory, or oral. But it's not unusual to hear patients talk about changes in their skin or improvement in their skin after cessation of dairy. It's just not well described in terms of incidence and correlation. There actually was an interesting paper that I'm reviewing for a journal. It's not published yet, but there may be an association between eczema and bacterial overgrowth. So if the symptom that they're having when they have different types of sugars is bloating and diarrhea, then it may be worth investigating a little bit further. That there's a connection between eczema and the gut microbiome. For the gut in general, I think the digestive tract in general, whether it be the microbiome or how we're metabolizing or breaking down nutrition or substances, probably is intertwined with our skin health. But whether it be because the patient is having some kind of a skin reaction to the dairy versus a microbial issue or something else, I think we still need to get a better handle on. There still needs to be some more research done in that area.
What is the test that you would ask your primary care physician for?
I'd say probably the hydrogen breath test. Because we can have false positives with bacterial overgrowth, it's probably best for the primary care doctor to exclude bacterial overgrowth. Again, that is just a different type of breath test that can be done with either lactulose or glucose. If they don't have access to a lab that does these types of breath tests, other options would be probably the lactose challenge, where patients take in that 50-gram load and we're looking at the plasma glucose levels. But again, it's a little bit more invasive. It does require getting stuck. And I think that the easiest or poor man's test is just if you drink a glass of milk and you feel really poorly, if you cut out dairy and you don't have those symptoms, that's a pretty easier poor man's test. But if symptoms persist after taking out dairy, then it could be that there is just some dairy in the food that you're eating. So that would be a better time to get testing.
The elimination is like a kind of at-home way of doing that too, of like, if I take out dairy, do I feel better?
It can be hard to do because dairy can sneak its way into a lot of things. If patients are eating out and they're having dressings, sauces, it can find its way into things. It can even be found in butter. So usually butter contains less of it, but if you're very sensitive, then anything that contains butter can also cause symptoms. So if you're unsure if your symptoms are all from lactose malabsorption and intolerance, then you can always get tested to be able to objectively measure.
Non-dairy substitutes like oat milk and stuff like that. Obviously, you can sub those in. What should you look out for in terms of calcium and vitamin D? I know a lot of them actually have added calcium and vitamin D. Is there anything that you should particularly pay attention to when thinking about a non-dairy substitute for milk?
Yeah, you hit the nail right on the head. You want to look for non-dairy options that have that added calcium and vitamin D, because if you're not, and you're not taking in much calcium and vitamin D, then you may find that you're getting deficient in those. Also, in New York, during the winter time, sunlight is actually what helps our bodies to synthesize vitamin D. It's probably worth checking calcium and vitamin D levels anyways, especially in the winter time. One thing that we don't oftentimes think about is in the summer when we say it's really sunny, we're out in the sun a lot, I must not be vitamin D deficient. When we wear sunscreen, it actually blocks our body's ability to make vitamin D from the sun. And sunscreen is really important for our skin health and to deter premature aging. But when we wear sunscreen, we're more likely to become vitamin D deficient because we block our body's ability to make vitamin D. Also, if we have a darker skin tone, it's harder to make vitamin D. So answering the question, yes, you want to look for non-dairy options that have calcium and vitamin D added to it, but it's probably something that's worth getting checked on a fairly regular basis if you are deficient, because you want to see that the levels, if you are deficient, are going up and improving with supplementation. It's very important for bone health to get adequate vitamin D levels. It's important even if you think that you're not a high-risk group, or even if you are eating dairy products. If you're using sunscreen or you're not outside a lot without sunscreen, definitely worthwhile to get checked.
Not a good reason not to wear sunscreen, because you want to make sure that you are protecting your skin at the same time. But that just complicates it a little bit in terms of how you're absorbing vitamin D.
Sunscreen can be protective against different types of skin cancers, also premature aging, but you may need some vitamin D supplementation if you wear a lot of sunscreen. So there's no real standard blood test. There's a complete blood count and a metabolic panel, which assesses for your white count, your hemoglobin, your platelets, and then a metabolic panel looks at different specific electrolytes and kidney function. I would say on a yearly physical, they're usually looking at your cholesterol panel, maybe a diabetes screen. Some primary care doctors will test vitamin D yearly, but if they don't, then it's something that you want to bring up. Because unfortunately, there's no like standard yearly panel that everyone adheres to. There's probably guidelines, but PCPs are only human as well. So if they don't bring it up and they don't order it, then it's something that we as the patients should bring up as well.